very good evening to all of you. I am Manisha and I welcome you all to the 5th Uveitis Grand Round, which is held by the Uveitis Society of India. Today's Grand Round is being presented by Rajendra Prasad Ophthalmic Center, All India Institute of Medical Sciences, New Delhi. At the outset, I will announce the winner of the last time's case presentations. So very hearty congratulations to Dr. Sabia Handa. And she presented a very nice case, which was an unusual case of intermediate uveitis. Does this patient need biologics? Congratulations once again, Dr. Sabia, and you win a free registration to the forthcoming annual Uveitis Society of India conference, which is going to be in October this year. So moving on, I have the privilege of introducing the esteemed panel for today's session. I have with me Dr. Russell. He is the professor of ophthalmology and pathology from the University of Alabama, Birmingham, USA. He currently also serves as the executive secretary for the American Uveitis Society and is a director of the Alabama Academy of Ophthalmology with a very keen interest in ocular inflammation. Welcome to the Grand Rounds today. Dr. Fernando is the chief of the Wilmer Eye Institute, Johns Hopkins University School of Medicine, Baltimore, USA. He again has special interest in age-related macular degeneration, diabetic retinopathy, along with a very keen interest in ocular inflammation. I welcome you both and thank you for joining in at early hours of the morning on a Sunday. We also have Dr. Rupesh Agarwal. He's the associate professor and senior ophthalmologist, clinician scientist, and deputy head of research at National Healthcare Group Eye Institute, Ten Toc Seng Hospital, Singapore. And he's a very dear friend to all of us. We have with us Professor Amod Gupta, sir. He's Professor Emeritus of PGI Chandigarh. He has done pioneering work on ocular tuberculosis, and we are all very much well aware of that. He's a Padam Shri awardee with several peer-reviewed publication and book chapters to his credit. But I think we all know him much better as one of the greatest teachers we have all had for uveitis. Dr. Vishali Gupta, I'm not too sure whether she would be able to join the session today because she is traveling. And if she does, I would just welcome her in between when the session is on. I would now introduce and invite Dr. Rohan Chawla, who is the additional professor of ophthalmology at Rajendra Prasad Center of Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. And he would be speaking to us on posterior retinitis from a clinician's perspective. Over to you, Dr. Rohan.
Thank you, Dr. Manisha. I would like to thank Uveitis Society of India for this privilege, and especially Professor Vishali and Dr. Manisha yourself for giving us this opportunity. And I would like to also thank all the panelists, especially Professor Amod Gupta and those of us who have joined us from internationally. Thank you very much for, we would appreciate your views on our cases and our perspective. So should I start my presentation?
Yes, please go ahead.
Can you see my screen?
Yes, you're good to go.
Okay. So I would be speaking on posterior retinitis, a clinician's perspective. So posterior retinitis, I have referred to it because most of the cases of retinitis that I would be talking about would have lesions at or around the posterior pole. So we have had some publications on this, some papers and some case reports. And so whatever I'm going to speak is based on the data in these papers. So why is it important, retinitis at the posterior pole? So as in any uveitis, we need to rule out the infective causes first. And herein we can see a lot of infective etiologies, which could vary from viruses, bacteria to toxoplasma. And additionally, we could also have non-infective variants. And these are very important because the lesions being close to the fovea or at the macula are vision threatening. And the clinician needs to think of starting some empirical therapy based on clinical clues. Although yes, certain other tests like immunological tests and PCR tests would lead to a final diagnosis and may change your initial conclusion. But if we have some idea or some working guidelines, an empirical therapy can be started. So now look at these 3 lesions. Now all these patients had evidence of inflammation in the eye and some evidence of retinitis at or around the posterior pole. Now when you see them, how can you differentiate or categorize them into different varieties as a clinician so that you can formulate a line of thought and an initial treatment? So let us discuss them one by one. So the first category we have put as a case where we have this fluffy sort of lesion right at the posterior pole with some minimal hemorrhages and vitritis. On the OCT, there is a full thickness involvement of the retina. So this is a very typical classical lesion described as a headlight in fog. The amount of fog may vary. So hemorrhages are generally fewer, generally mild or no disc edema, no macular exudates, no, or sometimes you can have associated localized fluid or even an exudative RD. But OCT shows that the lesion is starting from the retina and probably progressing towards the choroid. Later on, you can have necrosis of retinal layers, but still the ILM is spared for a long time. So this is the first group, which is toxoplasma retinitis. So here, in this photograph, you can see that as we have started treatment, the healing has started. You can see some empty spaces of thinning developing there, but the lesion is subsiding. So what we generally start is a sulfamethoxazole trimethoprim combination initially and add steroids later after about 3 to 5 days, generally 3 days. An alternative is you can also go for intravitreal clindamycin, which I think the PGI group has a lot of work on that. This is another similar kind of patient. Here you can see again that fluffy lesion, and you can see these empty spaces within that white patch of retinitis, which is where the necrosis has started occurring. Very few hemorrhages or nil in this case. Another patient where the lesion is much closer to the fovea. Here the vitritis is not that much, but when you see the OCT again, you can appreciate that the lesion is starting in the retina and progressing downwards. All these patients were treated as toxoretinitis with sulfamethoxazole trimethoprim, and they subsequently resolved. Now, does toxoplasma only present like this? Now have a look at this lesion. Now here you see that the lesion appears to be a little more deeper, a little bit more pigmentation, less white and fluffy. When I saw this, I initially thought that this is choroiditis. But when I did an OCT, I could see that there are definitely vitreous cells, and the inflammation is involving primarily the retina. In this patient, the tests which came out positive were HIV and toxo. And again, we treated this with anti-toxotherapy, and you can see resolution and scarring of the lesion with time. So here probably the HIV has altered the morphology a bit. So here I'm trying to present to you 3 categories of patients, and each category may not be a very watertight category like I showed you this patient, which is a little bit of an exception, but it will still give you a working idea. So the first category we talked out was toxoplasma. Now the second category includes a white stuck-on plaque-like lesion, which again develops intraretinal schisis. And as the schisis progresses, you start getting hemorrhages in the retina, not as an initial presentation. Again, there may not be much disc edema, not many hard exudates, but this leads to a marked necrosis of the retinal layers, and ILM again may be spared for a long time. And on resolution, there is thinning of retina with pigmentary alteration. So you see this patient, it presented to us like a white plaque-like lesion. You could even call it central retinal artery occlusion, but this patient had a lot of inflammation in the eye as well. Unfortunately, this patient came to us late and was already on oral steroids. And because of steroids as an initial therapy, the patient worsened, and central part led to a thinning, and the retinitis became fulminant, spreading centrifugally. And you can see this break developing in the retina, and we lost this eye due to a retinal detachment. But we stopped the therapy here of steroids and started an antiviral, valcyclovir. And the other eye, which showed smaller patches, that resolved. Although, yes, central retinal thinning was there, but we could preserve some visual acuity in this eye. Another patient, this is a young child, 10-12 years in age, came to us with again these plaque-like lesions. And you see that there are some clearing areas here where the schisis or the fluid is developing. And once this starts developing, you see this breakdown of retinal vessels and the hemorrhages developing. And again, this child we treated with anti-herpetic therapy first and added the steroids 5 to 7 days later. And you see with time, there is thinning of the retina with some pigmentary changes developing at the posterior pole, and the retinitis seems to be resolving. So again, what we learn here from COVID also is that when it is viral, do not start steroids at day 1. You should start steroids when you feel that the viral multiplication might have reduced. So initially the antiviral therapy, then you can add on the steroids after a few days. Another patient where we had these plaque-like lesions in both the eyes, and the patient also had an history of seizures. So here we kept a differential diagnosis of either a herpetic or an SSPE, but the patient also turned out to have a lot of lesions on MRI, and a brain biopsy revealed a simian virus. So this is again a very atypical case. But in this second category, I want to include viruses which are more neurogenic and they reach the retina probably via the neural route. So the initial hemorrhages are less, but they would develop once the schisis develops. And they initially present probably like a plaque-like lesion, and some of them may also have neurological symptoms. So herpetic, SSP, and probably a rare virus like a simian virus in this category. Now, up till now, what I have told you, if we just consider that, and if you look at this case, what would you think? So you see this case again has this fluffy sort of lesion, whitish lesion engulfing some of the vessels here, crossing them, but it also has some hemorrhages and it does not have vitritis, no discedema. So what is this? Is it toxo or is it something else? Well, then if I add a bit more to the history, you'll have a better idea. So this patient is a known case of leukemia. So patient is immunocompromised. So in immunocompromised, then our first line of thought always has to go to CMV, even if it is a localized lesion and not a rapidly spreading lesion. And in this, we did a PCR and we found it to be CMV positive, treated the patient with intravitreal multiple injections of ganciclovir, could not give oral valganciclovir as his counts were already low. And slowly you see the hemorrhages kept increasing, but with time, again, a lot of atrophy and the lesion does resolve and the patient is able to maintain about 636 vision in this eye. Now coming to our third category. Now here it is a little different. Here you see these are multiple patches. Sometimes they can be a little less in number also, but associated with that there is a blurring of the disc margin and you have these hard exudates developing somewhere around the posterior pole. If you look at the OCT, again it is quite different. You can make out the neurosensory detachment, you can make out the vitreous cells, the partial separation of the hyaloid and the thickening of the retina where probably the scan has passed through these retinitis lesions. So these, like I said, are single to multiple cotton wool-like fluffy lesions. They are associated with superficial and deep retinal hemorrhages. They can have disc edema and a macular star initially or eventually. And you see these cells and inflammation. So these cases are a miscellaneous group of cases which we have referred to as post-fever retinitis. And the common etiologies which we have seen in these cases are either rickettsia, Lyme's, Bartonella, or some authors have also described West Nile virus in the same category. So here we recommend starting an empirical therapy with doxycycline because it has a good effect for rickettsia, Lyme's and Bartonella, all of these. And viruses may be no effect, but it may not be harmful at least. And start again the steroids later. So give a gap of 4-5 days and you will find good recovery. As you can see in the slides here, that the lesions have resolved. You can see some Chiaralis arteriolitis developing, but which again I feel Chiaralis arteriolitis is a feature of any form of retinitis, even a toxoretinitis or even a Lyme's retinitis, both when healed. You could probably get this Chiaralis arteriolitis sort of feature. But again, the fluid at the posterior pole is reducing, the hard exudates are reducing. And here generally the visual recovery is good because the schisis in the retina and the necrosis is not that much. Another example of a similar patient, you see bilateral involvement here with multiple patches, and initially you have subretinal fluid, cells everywhere, and intraretinal fluid also. But initially we again treat them with doxycycline followed by steroids, and slowly you see they are resolving. These cases sometimes are also confused with neuroretinitis. So one has to be a little careful here. And we have seen that these post-fever retinitis, some people directly again treat with steroids, but in our personal experience, again, treating initially with steroids may not have that good an outcome as opposed to initially treating with an antibiotic or waiting for a few days and starting steroids. I think there is a similar paper on this from Narayan Netralaya as well. So you see how beautifully with time these lesions resolve. The retinal architecture appears to be near normal. And these patients sometimes even improve to 6/12 or 6/18 visual acuity. So we have done an analysis of some of these cases. And we call them post-fever retinitis because we found fever proceeding in them in about 75% cases. Some of them also had history of rash. We could get serology done in some of them, and some of them did turn out to be positive for rickettsia or Lyme's disease. So as I said, the recommended empirical therapy for these cases is doxycycline before we add steroids. So again, categorization, but I think the beauty of medicine is that you always have exceptions, and that exceptions will probably define the rule. But yes, you always have to keep in mind those exceptions while you are analyzing your case. So let us look at this case now. So here again, you see this is a patient which has this fluffy lesion here at the posterior pole. There are some hemorrhages. There are some clearing patches which might be suggestive of chysis or some fluid there, and some amount of vitritis. So what do you think? Is this case, according to you, what I have said, group 1, that is toxo, or would you say it is more rather a post-fever retinitis group 3? So if I add a bit more to the history, this patient also had history of hypopia on anterior uveitis in the past. And if you see the fluorescein angiography, the inflammation is not just restricted to the posterior pole, but there is widespread leakage from the capillary network, which is forming a fern-like pattern. And so this case was more of a Behçet's disease. And so Behçet's can also cause a posterior focal retinitis. And here our therapy was only steroids. So you have to keep everything in mind and all options open. And so a good history and a past history, past treatment history, systemic history, all that would help to guide you. And the fundus and the OCT are most essential, I think, for guiding the clinician in deciding the empirical therapy. And this needs to be started fast in these cases of posterior retinitis, because we want to prevent macular damage and definitely preserve vision. So again, to summarize the broad categories which I have said, what we generally now have in mind once we start analyzing such a case as it presents to us. The first one, most common focal retinitis, toxoplasma. The second one, viruses which probably are entering through the neurogenic route, herpetic, SSP, simian virus. Cytomegalovirus enters mostly through the endothelium. So I've just mentioned it here because I showed you a case, but CMV rarely, if a clinical situation fits in, can also be part of this. And the third is post-fever retinitis, where you have rickettsia, Lyme's, Bartonella, West Nile fever. And last but not the least, always idiopathic cases or autoimmune cases like Behçet's disease have to be kept in mind. And again, my message should be that in such cases, always pause, think of for a while. If there is an infective element to it, we need to treat that first, and do not be in a haste to start steroids. Thank you. Thank you for your patient hearing.
Thank you, Dr. Rohan. I think you really simplified the assessment of seeing a patch of retinitis at the posterior pole. I would now like to invite comments from the panelists. So can we start from Professor Amod Gupta, sir?
Yeah, I think Rohan presented very nicely illustrated cases of retinitis. And I think he's very rightly said, you know, retinitis, to my mind, is almost always infective. And the major difficulty I have seen going around India, you know, specifically, that people, the comprehensive ophthalmologists, are not able to tell the difference between an infective retinitis and a choroiditis, which most often is autoimmune disorder or have immune-related inflammation and needs corticosteroids. So he very rightly pointed out that, well, you don't start steroids, because that is what probably old-time teachers were telling us, that start steroids no matter what. You see inflammation and you start corticosteroids. I think if you start corticosteroids, and you have seen some examples from Rohan's cases, that you can have a disaster in your hands. So please hold your, you know, horses till you are able to tell the difference. And the only exception, as very rightly said, is times Behçet's disease, which has a very different spectrum from the other retinitis cases that is shown, because even if Behçet's present, mostly it will be presenting as vasculitis. And if the retinitis occurs, these are very transient. There may be multifocal, tiny, small. They last just a couple of days. They are not like the one we are seeing here, the full thickness retinitis necrotizing that he has shown in so many of these examples. So I think very high time that we able to tell the difference, and he's shown very nice examples. And major challenge I think specifically in South Asia face is these entities, now we started calling them post-fever retinitis, that come in epidemics like chikungunya, dengue fever, West Nile fever. And most of these cases have been reported from South India. And I think there are reports from Singapore, so we should be able to highlight that often, which are by and large caused by RNA viruses, unlike the herpes group, which is the DNA viruses. And we have specific therapy for DNA viruses, and we don't have any antiviral for these viruses like chikungunya and all you have them, dengue and all. And so most of these are actually immune-mediated inflammations, retinitis, and they would need to be differentiated from infective retinitis so that you can initiate appropriate therapy. One, the post-fever, like the ones that come in epidemics, need corticosteroids for quick amelioration of inflammation, whereas the infections, which he has shown so elegantly, I think they need a specific antiviral therapy. So I think very nice case is wrong. Yeah, this is what I have to say.
Thank you, sir. Thank you.
I'll go over to Dr. Russell. Any comment from you, sir?
Yeah, just excellent presentations. It emphasizes the point. The way I teach my residents is that you will never say never, but usually won't go wrong if you treat everything as if it's infectious at first until it shows it's not, because you're eventually going to start them on steroids anyway, even if it's an infection once you've covered for that or it's calmed down. Whereas if you assume something is not infectious and treat it as if it is an autoimmune condition, as you've clearly seen, you can get into trouble. So a great emphasis on that. Just an outstanding presentation.
Dr. Rupesh, any comment?
Thank you. As always, Rohan, a very good presentation and nice cases. A few points. When do you suggest when we see any patients of the retinitis, should we go in for anterior chamber tap, and maybe for the better audience to know how do we approach to diagnose? Just for the residents, I would like to say that as we try to approach, first of all, try and make sure that whether you're dealing with retinitis or choroiditis or retinochoroiditis, and I hope everyone can differentiate that can help. And then is there a component of retinal vasculitis also along with that? And most importantly, then to check whether it is active or inactive. And a lot of people, they don't pay attention to the deep vitreous cells. And I'm sure all of you know the technique about how do you examine the deep vitreous cells. And sometimes there will not be any anterior vitreous cells, and there are only deep vitreous cells, and you have to spend really a lot of time looking into that. But now, Rohan, and to the panelists also, is when should we go and do an AC tap or the vitreous tap? And let's say AC is quiet, and this question is always asked, should we go in quickly? And if you are planning, let's say intravitreal, let's say we suspect a group 1, what you suspected, and I want to inject antiviral quickly, because a lot of times this group of viruses do not give us time. I want to give in intravitreal, whether foscarnet or ganciclovir or whatever medicine you want to give intravitreally. At that same time, can we do also the vitreous step also? And the second thing is that where do you place syphilitic retinitis? You spoke about viral, and there is a question on the panel on the group chat also about the bacterial in the form of like TB. I know TB present mostly as choroiditis and maybe something. So where do we put these two as syphilis and TB in which group? Group 1, group 2, group 3? Where do we put, and about the invasive test? Thank you.
Okay. Thank you, Dr. Rupesh. So first of all, dengue and typhoid, which someone has put in the group, this I would again put into post-fever, like Professor Amod Gupta said. And TB again, yes, it can cause retinitis, but it is rare. And again, it would have a gamut of manifestations. It may have associated vasculitis and other chorioretinitis or pigmented lesions or other features along with it, not just in a single patch of isolated retinitis. And about the testing that you have asked, so I think we'll have some more cases here of peripheral retinitis. And there definitely we are doing a PCR at the same time when we are injecting the intravitreal. So at the same time, we do an AC tap, or nowadays we are even just using a minimally invasive single port 25 gauge. And with a cutter, we take a sample from that also if required. But in cases of only isolated posterior focal retinitis, with this categorization, I think as a step 1, we are not doing a tap, and we're starting the therapy. Only if we do not get a good response in few days, or if maybe if the immunological test suggests otherwise, then you go ahead and do a tap. So here we are not doing.
Yeah,
But I would welcome views of other.
Yeah,
other
just to share the Singapore context, I think we have Dr. Ho and my other colleague, Dr. Jensen, also there in the audience. And we try to be, if we can do, we try to do an AC tap quickly, the tetraplex PCR, which gives us at least the 4 different organisms. And if it is involving particularly the posterior pole, we try to be a bit more aggressive, because we do know that some of these viruses can spread quite fast and we don't have too much of time. Then we try to give intravitreal, while, or otherwise we start at least the oral antiviral tablets in case if we're suspecting a high level of suspicion while investigating the patient, because sometimes this test report, they come take some time. And again, as about the steroids, we try to defer the steroid as long as we can until we get the conclusive evidence about no infection, particularly from. But sometimes some of these tests takes a lot of time, and you have to rationalize your treatment. And if you really see if there is a fulminant retinitis and you have given antiviral for 2-3 days, and under that cover, you can some very rarely we consider that. But typically we try to wait to rule out the infective etiology. But if you have covered antiviral, then we start with these. But just to give you a kind of overview, not much of time to kind of share, but just to share. Thank you.
I'll quickly take one more question from you, Dr. Rohan, that would you be comfortable in giving a posterior subtenon tricot after you have given doxycycline for post-fever retinitis? This is another question being asked.
So you see, as a general rule, what I tell the residents is, when you're considering an infective pathology, why give a depot, which it will be difficult to remove or it may cause disastrous consequences. So I would rather just give an oral steroid in an infective pathology, which if at all, even if you want, you can stop and the effect would go. So I would give a depot injection only when I'm quite sure that I'm dealing with an autoimmune disease. So you give doxycycline and give oral steroids. And some of the cases I've even seen, you don't even need to give oral steroids. In 4 to 5 days, the exudate starts settling, the fluid starts settling, and they have shown good response also. But I would avoid posterior subtenon tricot for such cases. I think there's one more question about COVID. So in COVID, we have not seen retinitis per se. I'm most open to the others if they have seen.
I'll just take up some comments from Dr. Fernando also. Anything to add?
Well, it's difficult to add anything after 3 world-renowned experts have made comments, but I want to congratulate Rohan on an amazing presentation. It was very beautiful, emphasizes that something that I try to teach, that pattern recognition is very important to make diagnosis in uveitis. And he showed that very beautifully. But at the same time, we want to make sure we can pinpoint which one is the bug that is causing the infection, and first of all, differentiate between infectious and non-infectious, like Russell would say. It's very important. And then after that, then you. The exception, Rupesh alluded to this, is that if I start treatment immediately, and then I can try to do all the tests, including PCR, to make the diagnosis. But even if I have to wait, I just it may have the result the same day or the next day. I can change the treatment based on the PCR. Another thing that I notice is that steroids have to be started days after you start antibiotics or antivirals. And I agree with that. I usually start at 48 hours. I see that here he mentioned started 3-5 days later. I usually started a little earlier. I feel that inflammation in many of these cases is what really damages the retina and the tissue. And so I try to do a little earlier, but I want to make sure that it is covered at least for 48 hours with antivirals or antibiotics. But again, beautiful presentation. I really liked it.
Thank you. Thank you.
Thank you. So I think the consensus very much, which is coming out very strongly from all the panelists, is that for a patch of retinitis, I think we should be a little wary of starting steroids offhand. And you have to err more on the side of an infectious etiology for a patch of retinitis, and always start antiviral or antibiotics, followed by oral steroid at least 48 hours or more after you've started antivirals or antibiotics. Now, moving on to the next session, next section of today's session, that is the challenging case presentations. And now I would invite Dr. Vinod and Dr. Rajpal to kindly moderate the session.
Thank you, Dr. Manisha. We have with us Dr. Vinod as a moderator. Now, I would like to invite our first presentation, Dr. Aisi Sinha. She will be presenting a case. Dr. Aisi?
Thank you, sir. I shall be sharing my screen now.
Ayushi, can you please switch on your video?
Yes, sir. Right away. Just... Hello, sir.
Meanwhile, the presentation is set up. There is a question, Dr. Rohan, that where in India is West Nile virus antibodies are done?
Well, we have not done it, but I mentioned it because this case of West Nile was, I think, presented from Arvind, and they had probably got the PCR done from a military facility. If I'm not mistaken, I think Professor Amod Gupta might be remembering this case was presented in one of the uveitis meets. So I don't think an antibody is done, and I would probably not also rely on an antibody.
Okay. Okay, I think we can go ahead with Dr. Ayushi's presentation. Dr. Ayushi is a senior resident in the retina unit at RP Center, and she's a brilliant surgeon and a very good clinician. Dr. Ayushi, please.
Thank you so much, sir. Good evening, distinguished faculty and dear colleagues. I shall be discussing a very interesting case that we came across of positional amaurosis fugax and blue sclera. So we have a 39-year-old apparently healthy male with a chief complaint of recurrent transient diminution of vision in both the eyes for the past 3 to 4 months. The vision loss was associated with neck extension. The patient did not have any history of flashes, floaters, redness, or any other ocular complaints. There was no history of any known systemic illness in the patient, drug toxicity, allergy, or preceding trauma. On examination, the patient had bilateral uncorrected visual acuity of 6/6 and near vision of N6 with reactive pupils. The cornea and conjunctiva was unremarkable. The patient had blue discoloration of the sclera in both the eyes. Occasional cells, the lens was clear and the intraocular pressure was also normal. The picture shows blue discoloration of the sclera in both the eyes. On fundus examination, the media was clear with an average size vertically oval disc, a cup disc ratio of 0.4:1, healthy NRR with a sharp foveal reflex. The vessels appeared normal. Only on closer inspection do we see these small mid-peripheral hemorrhages. So we went ahead with an ultrawide field fluorescein angiography, which showed mid-peripheral microaneurysms, capillary non-perfusion areas, and there was no evidence of anterior segment ischemia, which was confirmed on iris fluorescein angiography. So here we have a apparently healthy 39-year-old male and after detailed evaluation of an unusual complaint of recurrent positional amaurosis fugax, which was present during neck extension, with near normal ophthalmic examination, with the exception of the mid-peripheral hemorrhages and blue sclera. So it suggests ocular ischemia. We went ahead with a cardiology and neurology workup. On physical examination, the right-sided carotid artery had a bruit and the left-sided carotid was not even palpable. The patient's ESR was raised. CT angiography revealed involvement of aortic arch vessels with thoracic aorta aneurysm. There was complete blockage in the left internal carotid artery and partial blockage in the left vertebral artery on the carotid Doppler. So a provisional diagnosis of non-specific aortoarteritis was made, which is Takayasu arteritis. CT brain was within normal limits. Patient on ENT review, the patient had bilateral tympanosclerosis with slight high frequency hearing loss in the left eye and moderate to severe mixed hearing loss in the right ear. So based on our findings of carotid artery stenosis with ocular findings, we have a case of ocular ischemia. Adding the blue sclera and the high frequency hearing loss, we needed to establish a diagnosis. Based on our patient's age, we looked into the likely systemic vasculitis or autoimmune pathologies. The Takayasu arthritis, Ishikawa diagnostic criteria for Takayasu requires the obligate criteria for age, that is less than 40 years of age, with major and minor criteria as detailed. Our patients fulfill the obligatory criteria with 4 of the minor criteria as highlighted here. Sharma et al. Modified the Ishikawa diagnostic criteria to increase the sensitivity, especially in the Indian subcontinent where the patients tend to present at a later age. So our patients also fulfilled the Sharma diagnostic criteria with 1 major criteria and 4 minor criteria fulfilled. The only concern in our diagnosis was the presence of blue sclera, which was not explained, and amaurosis as a presenting feature for Takayasu arthritis. We do know that ocular features in Takayasu presents a little late, but with a bit of literature search, we found this interesting case report, which although not present in their case, they talk about the presence of amaurosis, which is induced by neck extension due to vertebrobasilar disease. Amaurosis has been reported as a presenting feature of Takayasu arthritis, especially in younger age groups. So what couldn't be explained was the finding of blue sclera. Relapsing polychondritis is another differential, and our patient almost fits into the diagnostic criteria for relapsing polychondritis over here. Based on all this, the patient was started on oral steroids along with oral immunosuppressants and was scheduled for cardiovascular surgery. Thank you. The questions we would like to pose to the panel is what is their opinion of the most likely diagnosis? Have any of you encountered positional amaurosis fugax? And what should be the other diagnosis we should consider in this presentation? Which immunosuppressive therapy do you consider as first line for Takayasu or relapsing polychondritis? Thank you, RP Center AIMS, for this opportunity and Dr. Rohan Chawla for his mentorship.
Okay. Any questions?
So I have a question. So in terms of like differentiating between relapsing polychondritis and Takayasu's, I mean, in my mind, it's Takayasu's without a doubt. I don't think this represents relapsing polychondritis. The only confounding factor is your finding of scleral color changes. So I would dive more into that, trying to exclude that if I could as evidence of past inflammation. So the implication that blue sclera is a sign of inflammation implies there was previous scleritis. So, I would ask the patient if they'd had any previous episodes of the usual scleritis symptoms, that they had episodes of redness and severe pain, et cetera, vision changes prior to any of this. Because presumably you're saying that the blue sclera is a sign of, uveal show from past episodes, but there's other things that could cause blue sclera. I mean, it could just be, a nevus of Oda type thing, just pigmentation of the sclera. I'm assuming the patient wasn't a high myope and had a thin sclera because their uncorrected visual acuity was normal. But I think that trying to attribute that finding to an inflammatory disease is probably a stretch, and I think you have a pretty much a slam dunk diagnosis with Takayasu's. For that, in terms of treating that, if I thought that was the case, then steroids are almost always the first line therapy, and this can be prolonged or can take a prolonged course. So these patients are almost always going to need to go on to some kind of immunosuppressive agent, which most commonly in our hands is going to be an anti-metabolite and then transition to a TNF inhibitor, depending on how well things are controlled. And they can take a quite prolonged course of steroids early on. But again, I think it's a fabulous case. Great pickup, great job working it up. But I think to me, it seems almost assuredly like it's Takayasu's.
At what stage would you consider doing an ocular therapy, sir? If we have, this case is probably too early for an ocular therapy, but if you think the patient is going into ocular ischemia, at what stage would you consider doing a pan-retinal photocoagulation or anti-VEGF therapy in such a case?
Well, I probably would get an FA on the patient and actually, see the degree of non-perfusion if there was any. Going back, yeah, it's a good point. I mean, the ocular signs other than the blue sclera are due to ocular ischemia. The pressure, the intraocular pressure was normal, but low normal. You have these sort of very mild retinopathy type changes, and they had just a little mild anterior uveitis. Those are all classic presenting features of ocular ischemic syndrome. I would base any sort of treatment like that on FA. So FA, especially with wide field angiography, will really show you if there is any significant non-perfusion. If there is, then some prophylactic treatment in that area could be warranted. But, without that, I'm not sure that I would do PRP unless that FA guided information drove me to that. I guess the question is, with treatment, and I don't know the answer to this, so I'll ask the other panelists, is with treatment, I mean, is there any utility, any place for, carotid endarterectomy or other sort of reperfusion therapy to try to reverse the ocular ischemia? And again, I actually don't know the answer to that in Takayashi's. I'd be interested to hear what others say.
Professor Gupta, sir?
Yeah, I agree with Dr. Reed. It's most likely a case of Takayashi arthritis. And there's a big spectrum. We have seen a lot of these patients in experience in India, and there's a big spectrum. And I don't find anything unusual in this presentation, which I usually presented. And blue sclera is maybe a red herring, but then we know that scleritis is known. It's exceptionally rare case where scleritis could happen in a patient of Takayashi arthritis, but then we don't have any history of painful red eye, so there's no diffuse scleritis history available. The second, the relapsing polychondritis is just mentioned because without cartilage involvement, typical red pinna and saddle nose deformity, and without, the scleritis can be pretty bad in these patients. And there could be a peripheral ulcerative keratitis. So we don't see that. So I won't consider, although an overlap syndrome is known between relapsing polychondritis and, the Takayashi arthritis. So there can be an overlap always. So I'll be looking specifically at the patient rather than treat the syndrome. So here, the major challenge is not the eye. The major challenge is the aortic aneurysm, which is sitting in the thoracic aorta. And that is a danger signal because that shortens the lifespan of this patient. Okay, so I think whatever the cardiac surgeons or whosoever thoracic surgeon, they have to look at how they will mend this thoracic aneurysm. As far as the angioplasty is concerned, we've had patients where angioplasty was done. It remained okay for a while. It's difficult because unlike atherosclerotic plaques, the arteritic narrowing or occlusion of the arteries, these large arteries, is over large segments. So it's a difficult, challenging situation, but it's been done. It works temporarily, but bypass, as has been suggested in the presentation, that you bypass the obstructed segment, works very well. And I think from our group at the PGI, a reversal of these changes has been shown. So the ocular changes are reversible. I would not recommend doing a pan-retinal photocoagulation. I used to do a lot of that pan-retinal photocoagulation. It never works till you reverse the carotid ischemia. So that is the primary pathology. If we can do it, I think if we can do a successful bypass, patient would live to tell the story. That's what I feel is the case here. I would have loved if Ayushi had shown the angiogram to show a delayed perfusion in the arterioles, which is a very, very classic finding, a delayed perfusion rather than showing a late picture. A dye transit would have demonstrated very nicely for the residents and fellows who might be looking at this presentation right now. So I think from our group again, we have a video movie published in NEJM a few years ago, where you could show the cattle trucking in the vessels, which is a very, very classic a sign of Takayasu arthritis because of the slow perfusion. So I think otherwise it's a very nice case, and I think very high time we discuss these cases also, and not uncommon in our setting in India. Thank you.
Thank you.
Dr. Agarwal wanted to say something.
Yeah, a couple of points. I think as Professor Gupta just mentioned about that FFA. So I think this is a great case for FFA. And I think your approach was great, and I really compliment your team for approaching. I think good case for residents, and I would have missed picking up the amaurosis, and sometimes we ignore some of these findings. We say patients must be just bluffing and not paying, and a lot of times this patient would have gone to many ophthalmologists and those who would have ignored this finding of amaurosis, but picking up, I think that's my first take home point, that some of the symptoms you cannot just ignore. And a lot of times we come to us, we do a good peripheral fundus dilatation examination, don't see anything, but doing FFA from there was something really very good. And I think the certain clues which probably given you, the clue is the anterior chamber cells and all. So I think picking up those clues to do FFA, because not every single patient of amaurosis you do the FFA. So maybe something for us to learn. When should we do an FFA in the patients of amaurosis, or should we be doing in 100% of the cases? So that's something good. Other thing, yeah.
Sorry. You go on. Please.
No, other thing was I think as a follow-up, I can probably try and see if OCTA can be helpful in this case. I know peripherally it is not that great in the picking up the peripheral findings, but I think in this case I've done OCTA in some of the patients with cotton wool spots and certain emboli in the center. And you can see those capillary dropouts on the center. So I think good. My theory about the blue sclera, it's a little different theory. And I think what is happening here is the microvascular injury, and there is this small vessel disease. And whenever there is a small vessel disease, either in the form of inflammation and all, what happens is there is a lack of blood supply. So the blue sclera and all, sometimes it can be because of the ischemia, the scleral ischemia, which also happens in the patients with the chemical burns. And sometimes you really don't know. And this is called as avascular necrosis of the sclera, and where you can start seeing this kind of, not exactly the necrosis, but you start seeing the changes in the color. And we attribute it to the color change or something scleritis. So this patient will never get any episodes of full blown scleritis, but they get this blue sclera. And last point is that even though everything is great, sometimes one history which we need to take, we are okay with the diagnosis of Takayasu, but some of these things nowadays, there are funny drugs which people take. So some of these people might be on the drug addicts or some of those things. So I think a good detail, and particularly 39-year-old male, I will like to exclude any specific drugs if the patient is on, and we will be surprised to see, and all this, some of these drugs might come out, and if they have a prolonged history of IV drug abuse or some of those things, I'll be probably trying to rule that out. Do you agree, Vinod, Dr. Vinod, on that? Some of those drug history, maybe, yeah.
Yeah, I think so. We, in our scenario, most of the patients who are drug abusers, by the time they reach out to us, most of them are quite evident they are drug abusers. So somehow that is not the case. Not an early drug abuser probably never reaches us in our scenario. Dr. Rohan.
I just want to add one thing which Dr. Rupesh has already highlighted. So actually, when the resident first presented to me this patient and said he has 6/6 visual acuity and occasionally says that he can't see, we were just about to send him in a busy OPD. But then the red herring which sir mentioned, the blue scleras, when I saw the blue sclera, I said, let me just see this patient once on a slit lamp. And then I saw the cells, so I told him, please dilate the patient. And then we picked up the peripheral hemorrhages. And from there, the story goes on. So that's, yes, very important that we should not neglect these symptoms. Yeah, thank you.
Dr. Aravalo, please, would you like to make a comment?
Well, for me, it was more difficult to differentiate the diagnosis. I thought there were characteristics that were overlapping between Takayasu's and relapsing polychondritis. And I would have probably ordered an echocardiogram to see if there is any changes in the aortic valve that would lead me towards relapsing polychondritis. I agree with the changes in the aorta is most likely Takayasu's, and but there were several things that were confounding to me, like most of the cases that I have seen with Takayasu's, which is rare, have occlusive changes in the retina and vasculitis, and while patients with relapsing polychondritis can have these microaneurysms more commonly in maybe half of the cases. And so there were characteristics that lean towards one and another diagnosis. So I don't think the diagnosis was easy to make, but if I had to vote, I would say Takayasus. But I think at the end of the day, you treat the patient in a similar way.
Yeah. Thank you. Thank you so much. I think we, in the interest of time, we will go to the next case presentation.
Next speaker. Dr. Vinod, can you call you the next speaker?
Yes, sir. Yes, sir. So next speaker will be Dr. Prabhav. Dr. Prabhav is again a senior resident with us. He is very young and enthusiastic. He'll be presenting a case of, in fact, a series of cases of retinal neovascularization in patients with non-HIV CMV retinitis.
Good evening, everyone. I am Dr. Prabhav Puri, senior resident with Vitro Retina UVI and ROP services in Dr. RP Center for Ophthalmic Sciences. I am going to present upon proliferative retinopathy in non-HIV CMV retinitis. So going ahead with the presentation, a 61-year-old male had presented with us with diminution of vision in the left eye with a visual acuity of 6/36. He was diagnosed as CMV retinitis outside at another center and was referred to us for further management. The patient was a known case of non-Hodgkin's lymphoma. He had a history of radiotherapy given in the abdominal region and a history of chemotherapy. Completed a total 6 cycles of chemotherapy had been given to the patient. So the patient had already received 2 doses of intravenous ganciclovir when he had presented to us. At the time of presentation, he was on oral ganciclovir and on oral prednisolone. Earlier, a fall in CD4 count up to 34 cells per millimeter square was noted before the NHL treatment. At the time of presentation to us, the CD4 count was 248 cells. So on examination in the left eye, there was patches of retinitis with hemorrhages along with occluded vessel. In the right eye, there was no lesion besides a few lattices in the periphery. So a provisional diagnosis of left eye non-HIV CMV retinitis was made. Based on the diagnosis based on the features that it was mainly involving the posterior pole. There was absence of vitritis. There was mainly perivascular involvement. There were hemorrhages, and most importantly, the immunocompromised status of the patient. So confirmatory diagnosis was made based on vitreous sample PCR, which was positive for CMV. So for management, the patient was continued on tablet valganciclovir, which was 900 milligram BID for 21 days, followed by 900 milligram daily. Tab prednisolone 30 milligram was started in weekly tapering doses, and topical betamethasone and neomycin eye drops was given. So on 1 month follow-up, there was resolution of the lesion with the visual acuity achieved was 612 parts, along with chorioretinal atrophy in the region of resolution. On OCT, there was an epiretinal membrane with cystoid macular edema, along with chorioretinal atrophy corresponding to the heel changes. The patient presented 4 months after the resolution of retinitis with sudden diminution of vision, with a visual acuity of hand movements close to face in the left eye. On fundus, there was vitreous hemorrhage. On ultrasound, there was again vitreous hemorrhage was noticed with the multiple membranes there. So the patient underwent surgical intervention, pars plana vitrectomy with under laser. So on post-op day 1, this is Optos picture, we can see there's superior air bubble with the retina attached, and there are few endolaser spots. So the patient underwent fluorescent angiography post-operatively, and as we can see, there was extensive peripheral CNP areas along with the endolaser spots. Further endolaser augmentation was done on follow-up. In the right eye, again, there were only laser lattices. There was no CNP areas or there was no NV. So there was neovascularization there in this case, 4 months following the resolution. There were similar cases found there. This was a case of a 59-year-old female who had oral steroid-induced immunosuppression. The oral steroids was mainly given for underlying nephrotic syndrome. The patient presented to us with diminution of vision in the left eye. In the left eye, as you can see, there was intranasal CMV retinitis patch was there. In OCT, there was epiretinal membrane without any CME. In the right eye, there was no activity at that time. This patient again presented us with neovascularization on 4th month follow-up. As we can see, there was heel CMV retinitis there along with NVD and NVE there in the left eye. Fluorescent angiography was performed, and as we can see, extensive NVE along with NVD. The patient underwent laser phototherapy, and as we can see, there was laser CNP areas and fluorescent angiography of the laser. We can see extensive NVD, NV along with the laser spots. Again, there was another case of a non-HIV patient with CMV retinitis. This was a 24-year-old male suffering from acute lymphoblastic leukemia. So he was diagnosed to have CMV retinitis in both eyes. Again, he was resolved. There was resolution on medical therapy, and in this case, neovascularization was noted on 14th-month follow-up. So as we can see in the right eye, there is CMV retinitis along with resolution beginning. Again, in the left eye, resolving CMV retinitis can be observed. So in this case, the neovascularization was noted at 14th-month follow-up, and on fluorescent angiography, again, we can see new leaking vessels. So to summarize this case, we had a total of 3 cases of non-HIV CMV retinitis presenting to us with neovascularization: a 16-year-old male with non-Hodgkin's lymphoma, a 59-year-old male with nephrotic syndrome, immunosuppression due to oral steroids, and a 24-year-old male of acute lymphoblastic leukemia. So among these cases, 2 cases had presented on 4th-month follow-up after healing of the lesions, and 1 case had presented on 14th-month follow-up after resolutions of the lesion. Among these cases, only 1 case required PPV for vitreous hemorrhage. So I would like to question the panel: is neovascularization common in heel CMV retinitis? And if it is there, is it more common in HIV or non-HIV cases of CMV retinitis? And is there a difference? And if there is a difference, why would be there a difference in neovascularization among the HIV and non-HIV cases of heel retinitis? So thank you everyone, especially the retina team at the RP Center, Professor Rajpal sir, Dr. Vinod Kumar sir, and Dr. Rohan Chawla sir. Thank you.
Thank you, Prabhu. That was a nice case series. I would like to invite the comments of Dr. Aravalo. Professor Aravalo, what do you think about these cases?
So this was a group of very interesting cases. I have interest in these neovascularizations that can develop after CMV retinitis. We have reported a case, similar case, but on HIV, and an HIV case, and we have another one, similar case with HIV that developed retinal neovascularization later on. And the common feature on those cases is that patients had very low CD4 count, were on combined antiretroviral therapy, developed epiretinal membranes, so you can assume that patients had immune recovery uveitis, and that later on they developed neovascularization in areas of ischemia. So the retinal or the HIV microangiopathy that they may develop may be much more accelerated in patients that have had CMV and in patients that had immune recovery uveitis. So I don't think there is a difference between patients that are HIV and non-HIV in terms of the development of this late neovascularization in the retina. I think it occurs in both non-HIV and HIV. You are seeing it in cases with non-HIV not frequently because it's rare, but you're seeing these cases because most of the cases now that we see of patients with CMV are from non-HIV cases because they have immunosuppression for other causes, as the presentation well alluded to, while the CMV retinitis cases associated to AIDS have decreased significantly with combined antiretroviral therapy. So again, I don't see a difference. I have the opposite experience. I have more cases with HIV than without HIV. Something that caught my attention in the presentation was the use of steroids. I don't add steroids to CMV retinitis therapy. I think that patients are already immunosuppressed, and I don't want to add steroids. I don't feel they are necessary. The other detail would be that I don't just treat them for 3 weeks with valganciclovir. I add intravitreal foscarnet and or ganciclovir twice a week, but I want to treat them as long as it's needed, and only when I have almost complete resolution of the or healing of the lesions, then I turn to maintenance therapy. Those would be my comments, but great presentation for sure.
Hi, Rupesh here.
Yeah.
Thanks.
Dr. Agarwal. Yes.
Yeah, so I think great presentation, and I'll first of all compliment the team for this presenting these three cases. I think there are a couple of things I noticed. All three patients had a concurrent, and as you mentioned, it's a non-HIV. They have all three have concurrent systemic disease. First patient had non-Hodgkin's lymphoma. Second patient had nephrotic syndrome, and third patient had I think acute leukemia. And all three conditions are hyperviscosity syndromes, and all three cases, all three conditions, systemic condition, episodes of vein occlusions and has been reported. And it need to be seen. I've been managing CMV retinitis for quite some time, quite a number of patients of HIV and not that many patients of non-HIV CMV retinitis. I have not seen any single patient with neovascularization, though I know it's rare and there are cases been reported, but not so common. But I'm tending to believe, is it because of the underlying pathology and not related to CMV retinitis as such? It is a coincidental finding. I've got few patients with CMV retinitis and syphilis in them, CMV retinitis with HIV retinopathy in them. But having to associate neovascularization secondary to CMV retinitis, I am not able to kind of correlate. I will probably say might be due to primary pathology, which we do know that all three are hyperviscosity syndrome. That's just one of my thoughts. I might be wrong totally. And for CMV retinitis as such to lead to neovascularization because of the peripheral retinal ischemia and then leading to that, it's again a bit difficult to for me to put down a pathogenesis. But one point definitely I will agree with Dr. Agarwal is not to give oral steroids. At least I don't give oral steroids in any of the patients. And once again, if I feel the CMV retinitis is very fulminant, I try to give intravitreal foscarnet, 2.4 milligram in 0.1 ml if it is available. Not every center is available that. But for the zone 1 CMV retinitis, which is involving the posterior pole, I try to give them intravitreal ganciclovir with oral aciclovir 900 milligram, which takes some time to build up. And a very common thing, as you've very rightly mentioned, that one of the patient, I think one of the cases, next case is coming up is the low blood counts. So you have to monitor the renal function when the patient is on ganciclovir, because we have few patients who have gone into the renal failure post ganciclovir. So those are some of the thoughts. But yeah, I'll just like to point towards the systemic disease. Thank you.
Professor Gupta, sir.
I think the presentation of these cases is excellent, and I think it was high time to flag these complications of CMV retinitis in non-HIV population, which people all over the world are now increasingly seeing this complication. And I like to tell that now there are a number of series in the last 20 years that have shown that CMV retinitis in non-HIV patients is far more aggressive, more extensive. It's got arterial involvement, arteriolitis, and capillary non-perfusion ischemia is far more profound. And the complication of neovascularization is therefore far more common in these patients than in the usual HIV CMV retinitis. Whereas Dr. Agarwal mentioned, the CMV retinitis neovascularization in HIV patients is a little rare, occurs late at the time when there is a immune recovery uveitis. So I think presence of inflammation has something to do with it. And usually these vessels we seen growing as a fibrovascular plaque asymptomatic very often. Unlike non-HIV patients where these are highly symptomatic patients. So, so these are some of the differences. And the reason why people postulate is that unlike HIV, we have both the cytopathic effect as well as the immune response. So there are two mechanisms which are working concurrently in non-HIV CMV retinitis, which may be responsible for the kind of aggressive nature that we have seen in your patients, and what is now reported, at least 3-4 large series are now available And two, we have seen all those non-HIV CMV retinitis, because at one point of time in India, we were seeing being a major, center for transplant and for malignancies and leukemias. We used to see these children and adults with a lot of CMV retinitis, much more than we were seeing in HIV patients. So these complications now we know are much more common in non-HIV CMV retinitis.
I also thought so, sir, because I had seen quite a bit of HIV CMV retinitis. I myself had never noticed proliferative retinopathy happening in these eyes. So what I thought initially was probably vascular involvement was much more in these eyes, and that's why these eyes were developing proliferative retinopathy. Your comments, Professor Reed?
Yeah. Again, fascinating series of cases. I almost exclusively see non-HIV related CMV retinitis now. Interestingly, of course, before the HART era, HIV patients who developed CMV retinitis had about a 6-month average life expectancy. So we never saw late complications from CMV retinitis in HIV patients before that. And then HART therapy probably alters the course of all diseases, not just the fact they don't get CMV, but it could alter the fact that maybe that's why we didn't see neovascularization as much, and it's a different disease now. I think that in these particular cases, which again, I think this is a very rare complication, I think Rupesh is right in that it's probably, I think, a combination of the two, the underlying disease process, systemic disease, and then the CMV overlaid on top of that. And I think that's illustrated by one of the cases, I believe I'm right, was unilateral, right? So there was a unilateral case of neovascularization. They had lattice in one eye. And so if it was solely the underlying disease, why would they get neovascularization in only one eye? And that eye was the one that had the CMV. So my theory would be that the underlying disease set the stage, and the CMV was an additional stress on top of that resulted in the neovascularization. But it's interesting in that I wonder, should we be doing FAs in patients at the conclusion once their CMV is quiescent to see the degree of non-perfusion and ischemia, and so that we watch them more closely for this? Maybe not, because it's such a rare complication, but it's still an interesting idea. But great series of cases. Congratulations.
Thank you so much.
If I can make another comment, I remember some case. Thank you. I remember some cases of macular ischemia associated to CMV retinitis. So maybe again, not unheard of that could happen in the periphery and lead to retinal neovascularization. But I agree with all the comments. It's something that is very hard to be sure at this point.
Thank you.
Okay.
Professor,
thank you. Now you can invite.
Okay.
No, thank you. Now next speaker is Dr. Mosmi Banerjee. She is a senior resident in RP Center.
Hello, sir. Am I audible?
Yes,
Yes.
Mosmi, you are audible and your video is clear.
Okay. Good evening, everyone. I'll be discussing a rare case of atypical peripheral retinitis. So, a 38-year-old male presented with sudden onset painless progressive diminution of vision in the left eye since 3 months. There wasn't any history of recurrent redness or any history of fever, maculopapular rashes. However, there was a history of use of oral steroids, which were prescribed to the local practitioner for the diminution of vision. There was a single episode of seizure 2 months ago, for which MRI brain was conducted, and it revealed tiny focus of calcification in the right parietal lobe. And the patient was started on anti-epileptic medications. On ocular examination, we saw a visual acuity of 6/6 in the right eye, and left eye revealed a visual acuity of finger counting close to face with projection of rays accurate in all the quadrants. There were diffuse KPs on the endothelium with the anterior chamber cell reaction of 1+ with retrolental cells in the left eye. On fundus examination, a media haze of 1+ with diffuse peripheral retinochoroiditis, arteriolar involvement, and sectoral pigmentary retinopathy in the inferior quadrant was noted. Right eye revealed a temporal pigmented scar. On OCT, the central macular thickness of 247 and 279 microns were noted in the right and left eye respectively. So coming to the systemic investigations, the patient had a normal blood count. However, there was an elevated ESR level. The patient was non-reactive for viral markers, and there was a markedly elevated toxoplasma IgG of 650. We came to a diagnosis of diffuse peripheral retinochoroiditis with inferior pigmentary retinopathy in the left eye with temporal pigmented scar in the right eye. We started the patient on oral cotrimoxazole combination, oral cotrimoxazole BD with topical steroids and topical cycloplegics. Oral steroids were started after 48 hours of initiation of the antibiotics with oral antacids and vitamin C supplementation. At 2 weeks follow-up, a visual acuity of 6/18 was noted in the left eye with reduction in vitritis, healing retinitis lesion, and sclerosed vessels. Right eye was stable. And on angiography, staining of the healed scar in the left eye as well as in the right eye was noted. At 4 weeks follow-up, a visual acuity of 6/12 was noted in the left eye. So coming to the differential diagnosis, the first and foremost differential diagnosis which came into our mind based on the clinical feature was acute retinal necrosis. However, there was very minimal occlusive retinal arteriolitis, no circumferential straight noted, and despite not starting the patient on antivirals, there wasn't any rapid progression in the retinitis noted in our case. So the second differential which we thought about was ocular toxoplasmosis. Under normal circumstances, we won't think of ocular toxoplasmosis as a differential for a peripheral diffuse retinitis. However, our patient had arterial involvement with vitritis, retinochoroiditis, toxoplasma serology positivity with response to treatment to toxoplasma with a pigmented scar in the fellow eye. Therefore, we thought of ocular toxoplasmosis as a differential. Now, based on this atypical presentation amused us, and therefore we did a little bit of literature search, and we noted that atypical ocular toxoplasmosis is a well-known entity which has been described in literature, which is characterized by large multifocal and/or bilateral lesions. Patients, elderly patients, and patients who are on immunosuppressants are at high risk of having such clinical feature. Now, it mimics ARN, and there are certain features by which we can differentiate it from ARN, like severe obliterative retinal arteritis with pain on eye movement, retinal hemorrhages, involvement of peripheral retina for 360-degree, and pseudocode-like projections, which are usually noted in ARN and not in toxoplasma. Further treatment with corticosteroids for severe posterior uveitis without institution of specific microbial therapy, as was done in our case, may induce an immunocompromised state and allow the chorioretinitis to progress at a more rapid rate. So prompt diagnosis and early initiation of specific therapy is required for a better visual outcome. And since it's a diagnostic challenge, therefore combination of PCR-based assays along with serological parameters might help in early diagnosis in such challenging situations. Now, I'll just like to quote one study in which 22 patients with widespread chorioretinitis resulting from toxoplasmosis were examined between 1990 and 2001. 73% cases had received steroids and 50% received antiviral therapy before the accurate diagnosis of toxoplasma. The clinical feature was similar to our patient, and the diagnosis was made solely on the clinical response to anti-plasma medication in 4 patients and combination of PCR, serology, and histopathology in 16 patients. We ruled out other retinal causes, differentials of retinitis like PORN, CMV retinitis, and syphilitic panuveitis, as our patient did not have the classical feature of these diseases. So my take-home message will be ocular toxoplasmosis can present with atypical features of large diffuse peripheral retinitis, especially in immunocompromised patients. And differentiating from ARN is very important in such cases. And examination of fellow eye is very important, and it should never be undermined. So my questions to the panelists will be, our diagnosis was based solely on the clinical findings and clinical response to treatment. So would you have preferred a PCR-based assay for the diagnosis? And would you have preferred any other different treatment approach? And have you encountered in such a typical presentation of toxoplasmosis, which mimics herpetic retinitis? Thank you.
I think I would first ask Professor Russell Reed. Sir, have you seen such atypical presentations of toxoplasma causing a mid-peripheral or a peripheral retinitis?
Yes, absolutely, several times, and almost always in the setting of the patient presenting elsewhere and being treated with steroids in some capacity, frequently periocular or intravitreal, unfortunately, steroids. So have I seen that presenting de novo? Some, but again, much more commonly in the setting of inappropriate treatment initially. I think this is a fabulous case, and it really emphasizes a lot of the characteristics of what you were discussing in your talk at the very beginning of this this meeting, that you have to have a high index of suspicion and fairly wide differential when you first presented with any kind of retinitis. What I would have done if this case had presented in my clinic like this, it's a retinitis. I'm assuming it's an infection. I don't know if it's viral or toxoplasma. That would be the two highest on my differential. So I would have tapped the AC to send off for PCR, treated intravitreally for antiviral, but then also covered for toxo. then I've covered all the bases of the most common, at least this is in the practice where I am. Then I've covered for all of the possible infectious things or the most common infectious things. And while I'm waiting for the results of the PCR and the serology, which I'm also going to do to come back, at least I've covered everything. And then as we discussed previously, usually around 48 hours later, we would start steroids. So I've covered, the two most common infections, toxoplasma and viral retinitis, and I've covered for autoimmune diseases within 48 hours of the patient presenting. Once the data comes back, then I can change my empiric treatment to more directed treatment. And in this case, I think you're absolutely right. It's toxoplasma. Of course, you could also, if you're really, really worried, and sometimes these cases will present with such dense vitritis you can't see. You suspect there's a retinitis, but you can't see anything. And I'll have these patients see my retina colleagues. I do uveitis alone. I'm not a VR surgeon, but we have a really good set of such surgeons here, and we'll actually go in and have them do a vitrectomy, even in a hot eye, because we really need to know what's going on. Then you have a huge sample for additional testing, and you can leave antivirals as well as clindamycin in the eye. And again, also at the same time, send off serology. So that's the way I would have approached this, just because not knowing for sure what the nature of the infection was, because my pattern recognition, as Fernando was mentioning, which is critical, can be altered by someone else's pre-existing treatment. I don't know for sure what I'm dealing with, and I want to cast a very wide net and not miss anything.
Thank you, sir. One learning point for us also was that in our usual workup, we generally were not doing PCR for toxo. Whenever we were taking samples, we were doing mainly for viruses. But after this case and also going through the literature, now I feel that whenever we find something is atypical, one should probably add toxo to that list as well. Professor Amod Gupta, sir, your comments, sir?
I think by and large covered by Dr. Reed, the discussion of this patient. One point I'd like to add here is that look for some clues, like a pigmented scar. Now, if you see that kind of a scar, it strengthens your suspicion of a toxoplasma lesion. And I guess your patient did have those pigmented scars. We have actually reported some years ago 2 such patients where on vitreous surgery, there was so much confusion, that we had to do a vitreous surgery, and we could actually, demonstrate on cytopathology the presence of toxoplasma cysts, on the surface of the necrotizing retinitis. Because as Dr. Reed mentioned, when somebody exposes these patients to corticosteroids, it's very difficult, challenging to tell the difference from a viral retinitis and a toxoplasma retinitis. And, you mess it up. And that's why, as he rightly said, I would have also done at least an AC tab, which is very, very sensitive for viral infections, at least of the herpes group, not as sensitive for toxoplasma. Specifically, if the patient happens to be immunocompetent, the PCR positive would be rather low, but if it were positive, it strengthens your diagnosis. So if we did a tab from the vitreous, or like I think in the beginning, if I remember correctly, Dr. Rohan Chawla mentioned that they don't hesitate to go in with a 25 gauge vitreous surgery, in some of these patients to obtain sample rather than put a needle into the vitreous cavity, which is hazardous, to say the least. So I would go in without hesitation and do a vitreous surgery in these patients where there's a confusion about the differential diagnosis, because you can salvage the eye and there is no deleterious effect of small gauge vitreous surgery on posterior uveitis and retinitis. And in fact, we have reported excellent outcome wherever there has been a doubt about the diagnosis in this patient. We have gone in and done the surgery, and we've had excellent outcome. And we reported Dr. Some Basu from Bhubaneswar reported similar kind of results. That if you're in doubt, don't hesitate, don't blindly start any treatment. I won't blindly treat a patient. I would like to have a reasonably firm diagnosis to begin my treatment. I'll not try to do a cocktail. Moreover, you must realize if this patient didn't have actually had probably exposure to corticosteroids and was not really expressed that way or HIV positive, because in those patients there could be multiple infections simultaneously. And we have had patients here, where you had VZV as well as toxoplasma, which again produces similar kind of phenotype, in immunosuppressed individuals. So it's very difficult. You could have treated only for toxoplasma or treated for VZV, and you don't know whether the patient is not responding, why is not responding, because mixed infections in immunocompromised patients is well-known phenomena. So for that reason alone, I would have preferred going in, and you were indeed very fortunate that patient had excellent outcome, and you could save this eye based on the serology. So that was somehow a sportive test in favor of toxoplasma. But I wouldn't have ruled out a viral infection simultaneously, because we have seen people who have received Kenalog, posterior subtenon or intravitreal Kenalog would have a local immunosuppression, and you could have, kind of multiple infections right there in the eye.
Sir, there is a question on the chat box by Dr. Ali. The question is that if atypical retinitis and we are waiting for the PCR results, should we give oral treatment for both toxo as well as antivirals at the same time?
No, this is what I mentioned, that I like to, patient already has a necrotizing retinitis. Unless you have a clinically very firm diagnosis, you won't like to start, because you will mess up again. You see half response, you see partial response, or you see no response, and then you're lost. You don't know what to do. So why not spend a day? And I think your PCR lab has to report within matter of, if you gave the sample in the morning, they should give you by afternoon. It shouldn't be a matter of days reporting on PCR. It's a matter of couple of hours, and you need to, in fact, sensitize before drawing a sample. You have to put the lab on alert and tell them, look, you should expect an urgent sample for processing within the next few minutes or half an hour or 30 minutes, and you will get a result within 30 minutes, within a couple of hours. It doesn't take that long for PCR. That's the beauty of this particular test. Only thing, if we do it as a routine conventional lab test, they may not know the urgency. So here somebody's eye vision is at stake. So you have to alert the lab, and you have to emotionally convey the urgency with which you need that lab report.
You are muted, sir, Dr. Rohan.
Dr. Fernando, your comments, sir?
It was a great presentation. I think that it emphasized the error that starting steroids on patients that may have an infection will mess up the whole clinical appearance. Like Russell said, we like to rely on pattern recognition, and everything disappears in terms of pattern recognition. When patients are treated with steroids, everything will change. Yes, I have seen these cases before, and I like to get a workup and yes, have a confirmation by PCR or serology so that I can treat appropriately. But like Rosa, I'd like to start my patients on antivirals immediately, because that's the entity that is going to progress more rapidly, and I can wait until I get a PCR the next day to start anti-toxoplasma therapy if it turns to be toxoplasma, like in this particular case. And I thought that at the end, ruling out syphilis, I love that comment because all the trainees in this webinar should always remember that this is the thing that we should always test for in uveitis. You should never fail to test for uveitis because it can show us anything in the posterior pole.
Thank you. Professor Rupesh, I would like to ask your comments on, can you highlight something more on PCR, on the process, and what specifically you ask for routinely in your cases when you do PCR?
Yeah, I'll come to that. I think that's important. And I totally agree with Professor Russell Reid's approach and about the way we treat it. And I wanted to add the syphilis, which Professor Revelo just added. So I would have added to my differential diagnosis the list of syphilis, though I would not have started treatment. But slightly, I would like to differ from Professor Amod Gupta. Usually I never differ, but in this part, we struggle quite a lot to get the PCR. Sir, you have a great lab at PGI to get the test done within few hours, and maybe at RP center they have, but I'm sure a lot of our colleagues, they don't have. And even in Singapore, we struggle to get it up to 48 hours or so. So what we do as a uveitis specialist, I will take a fundus picture or whatever the documentation is needed, a good fundus picture, good OCT. I would have done FFA at the beginning mostly. I don't think you've done it at baseline. I would have probably done the FFA early then rather than waiting. I don't know whether the FFA which you have shown was done it early. I will probably do it at baseline immediately.
Yes, sir, FFA was not done at the baseline.
So I will do and peripheral pictures, the pictures where posterior pole not taken completely. I will take those pictures. Whitefield, now Whitefield is available, and montage or whatever thing is required, and FFA. And coming to the PCR, we want to do, and I try and emphasize that even if anterior chamber is quiet in this patient, though in this patient there were KPs and anterior chamber cells, definitely AC tap is a good option rather than going in for vitreous, which can be a little bit more complicated as compared to that. AC tap, we send it for, typically if we send it for tetraplex PCR, which we send it for HSV, SZV, CMV, and toxo. So this is the typical which we send, all the four. We try to take up to 0.1 to 0.2 ml of it, if we can do that. And immediately the sample is sent out to our labs. They take up to 48 hours to come back. But in the meantime, we start the patients on antiviral treatment. And in this patient where I was high suspicion, I will give intravitreal foscarnet, one injection while waiting, because it probably will not cause any harm. And even if it has to change the pattern, as Professor Gupta said, probably at least I have kind of documented what I've been treating for, and I've sent the sample. And in the meantime, I'll start antitoxoplasma. In this case, the serology was not very supportive, I will say. The IgG being positive itself, I get lots of patients even double the serology of IgG positive in this, but they are all negative when it comes to the PCR from the eye for toxoplasmosis. In this case, just being IgG positive was not that supportive. I will probably go with the clinical judgment, what you did, rather than just with the IgG positive, because IgG is not that supportive of toxoplasma being positive, But yeah, that's the sample. And another point to add, if I have to take a vitreous sample, and as Professor Russell Reid also said that, I will do it when it is required, but at the same time, I will send that sample for 16S ribosomal RNA, which I've been sending. And if the center is available, I know in US and lots of centers in UK and Europe, it is available. India, I'm not quite sure, because that gives you really a clue on what exactly you're dealing with. And there is a large case report series published from 3 eye centers from US, Boston and all, and where they published about 450 cases of 16S ribosomal RNA. How does it help you in the diagnosis of some of these atypical pathogens? And this is one of those cases where we are dealing with atypical pathogens. So I think it is good to send the sample when you do a diagnostic vitrectomy and send those for 16S. Yeah, those are my comments. Thank you.
Thank you. So actually, we have done few cases of 16S RNA, but that we have done for endophthalmitis to know whether it is a bacterial or not, but we have not done for uveitis cases as such. But that is a good suggestion. Maybe we can go through that. There is one comment in the chat box by Dr. Sivkan Balchi. She says that they have seen such cases of atypical toxoplasma after COVID. So that is their experience. And there is one more comment that intracranial calcification appears to be related. Well, maybe it might be related. That is why we also mentioned it in the presentation and did not want to ignore even any other finding. Okay. So I think if there are any other comments, or should we go to the next case?
I think, sir, time is running, so we have to move to the next.
You can go to the next case.
Okay, so I invite Dr. Nawazish, who is also a senior resident with us, retina as well as uveitis. And Dr. Nawazish, please go ahead.
Yes, Good evening, respected faculty members and my dear panelists and my colleagues. So I'm basically presenting on the conundrums in management of acute retinal necrosis under the aegis of Dr. R.P. Center. So a 25-year-old female presented to us with complaints of diminution of vision associated with redness and pain in her right eye for the past 1 week. She presented to us on 12th March. She had history of epilepsy as well as she had undergone left eye cataract surgery in 2014 for a total cataract with a closed funnel RD, and she was left aphakic in that eye. Her past history, she had similar episodes of blurring of vision in February as well as in March. However, in March, she was diagnosed as uveitis and started on topical medications. On 5th of March, after her uveitis, workup was found to be within normal, especially the HIV, VDRL, serum ACE, and chest X-ray. She was diagnosed as acute retinal necrosis and prescribed tablet valacyclovir 1 gram TDS, and on subsequent follow-up of 7th March, she was started on tablet prednisolone 40 milligram. However, when she presented to us on 12th March, she had significant inflammation in her anterior segment as evidenced by the mutton fat KPs as well as AC cells and flare and iris nodules present. On posterior segment evaluation, there was presence of media haze with significant vitritis. The disc was hazily visible and we could see temporal patches of retinitis. Although the occlusive vasculitis was not very clear at this point. So this was the image. It showed vitritis and a large patch of peripheral retinitis. So we went ahead and confirmed our diagnosis of acute retinal necrosis, and we started the patient immediately on IV acyclovir as we wanted an immediate response as she was one-eyed. Her oral steroid was discontinued immediately as she had been given for less than a week. Similarly, her oral steroid was restarted on day 5 of IV acyclovir therapy, and she was eventually shifted to tablet valacyclovir 2 gram TDS at 7 days, and she was eventually discharged. On the first follow-up, she was found to have reduced vitritis. Still, there was a peripheral patch of retinitis visible, and now we could see occlusive arteriolitis very well. She was doing well on her follow-ups in the first week, but unfortunately on day 12, she presented to us with sudden onset diminution of vision with a visual acuity of hand movement close to face with total RD with significant vitritis. So at this point, we went ahead with a right eye encirclage VR surgery with silicone oil in situ with under local anesthesia. So this is the surgical video of the same. At the same time, we took vitreous biopsy and sent it for PCR for CMV, HSV, VZV, as well as toxo. We went ahead, stained the membranes, removed all the membranes at the posterior pole, did ILM peeling, as well as removed the membranes holding the temporal retina taut. This was done very meticulously under PFCL, ensuring complete removal and release of the retina, especially the temporal retina. All around the temporal part of it, there were multiple membranes at different levels which had to be removed. A fluid air exchange was done. And we completed the surgery by doing a 360-degree laser. So on post-op day 7, we had the vitreous biopsy, PCR positive for HSV. The retina was attached. She had a visual acuity on 1/60 and was ambulatory with the same. So our questions to the panelists would be, although there has been a paradigm shift from use of IV acyclovir to the oral formulation, what is the actual preferred antiviral that you use and what is the route and dose that you prefer? A small literature search showed us that valacyclovir at doses of 2 gram 4 times a day is equivalent to use of intravenous acyclovir 10 mg per kg. Our second question would be, after how many days would be the ideal time to start systemic steroids? As we saw in our case, it was started within 2 days of starting antiviral therapy. And our third question would be, is there any role of encirclage? So a study done for long-term surgical outcomes of ARN had very small sample size, and they only did 4 cases without an encerclage, whereas 7 were done with an encerclage. And is there any role of early vitrectomy? Again, a case, a meta-analysis done by Fan et al. Showed that there was role of prophylactic vitrectomy, that is in patients without retinal detachment, but their series again was very small and it only included around 240 eyes. I would like to thank all my mentors at RP Center, Professor Rajpal, Dr. Rohan, Dr. Vinod, Dr. Shaurya, and Professor Parijat Chandra, and my colleagues at RP Center who have ensured that I have continued learning over here. Thank you.
Thank you, Dr. Nawazish. So we have had this comprehensive symposium, I think, on retinitis, and I thought the last case should be the acute retinal necrosis, which most of us most commonly see. So I think, first of all, I would like to ask Dr. Russell regarding the dose of antiviral and the route which you would prefer nowadays for the standard acute retinal necrosis, which is mostly a herpetic etiology.
So my standard practice for quite a few years now has been when I highly suspect viral retinitis, an AC tab for PCR, as we've discussed, and then intravitreal antiviral, usually phoscarnet because it's the easiest to obtain straight out of the vial and straight in the eye. And then we do double dose Val acyclovir, so Valtrex, the brand name here. So 2 grams TID for at least a week. And the reference you showed is exactly why we do that, that you get essentially equivalent levels of antiviral activity intravitreal as you do from IV acyclovir. And then we repeat the intravitreal injections usually early on every 2 days. They used to be less often than that until we see definite evidence that the retinitis is calming down. And I typed a response to one of the questions in the Q&A box about that, you know, that things will look worse before they look better because there's dead necrotic retina at the edge of those areas of retinitis. It just hasn't become opacified yet. So the surface area of the retina will look worse over the ensuing first few days, even though you are getting ahead of the infection. But that's the key thing. I mean, the whole point about trying to prevent retinal detachment is dependent on reducing the surface area of retina involved in the infection, because the larger the surface area of retina, the more chance there is for tears and traction and detachment to occur. And the best way I know to do that is to get the absolute highest level of antiviral activity I can right where the infection is. And the best way to do that is intravitreal. And then you put the double dose Val acyclovir on to supplement that. But also, I would argue equally as important to protect the other eye, because this can become sequential and involve the other eye as well. So, and I do that for at least a week if the patient has normal kidney function. And of course, at the same time I'm doing all this, I'm also going to do serology because I'm going to rule out syphilis and other things. I'm going to do a CBC and a metabolic to see what the patient can tolerate. I may go even longer than a week at that double dose of Val acyclovir. If they have somewhat compromised kidney function, I would do it for no more than a week, though, just because it can be quite rough on the kidneys. But the key to me is get as much antiviral into the eye where the infection is as absolute quickly as you possibly can.
So in our country, I think phoscarnet availability is a problem. So I would ask Professor Amod Gupta, sir, what would be your approach for a strong antiviral? How would you approach this?
No, we've been following, there's a difference in the approach, probably in the United States vis-a-vis India, because we find admitting these patients far more cost effective than it would be with Professor Reed, I believe. You know, so we like to admit a patient and like to administer intravenous acyclovir. Again, the cost factor, you know, the valcyclovir probably is going to be more expensive, but it's a good choice, you know, when you want to. But all my patients have treated with standard intravenous acyclovir for about 5 days, followed it up with oral valcyclovir or oral acyclovir, either of these two. The important thing is, again, you know, about the role of early vitreous surgery or retinal detachment. Now, we must realize that retinal detachment occurs in these patients a few weeks down the line. And majority of these patients are going to, a substantial number will develop a retinal detachment. And that's because the time they start developing vitreous detachment. And on a atrophic necrotic retina, when the vitreous starts detaching, and those of us who had some experience of operating in these patients would find that the vitreous gel appears to be very tightly adherent to these areas of necrosis. And by the time you are trying to peel off or remove the vitreous from this necrotic retina, it tends to tear off. But otherwise, you would find that the reason why they develop is because of those sieve-like retinal breaks that they develop. Now, why I would not like to inject intravitreal? One you said phosphorite is not even available in India. The other is I wouldn't like to do any intravitreal intervention because it may herald the onset of posterior vitreous detachment. And if you iatrogenically, disturb the vitreous, you may herald the onset of retinal detachment, earlier than it would happen in a natural course. The same subject, I do not do a prophylactic vitreous surgery, because I find it's a lot more invasive in these patients than when you really develop the earlier sign of retinal detachment that you see, that you will go in and do the surgery. I would like always to put encircling in band. That was one question asked by Rajesh, and that is the reason is because removal of posterior hyaloid from the peripheral retina in these patients is easier said than done. So to prevent any, to mitigate against any later contraction of the posterior vitreous face, which is still there, and cause fibrosis and retinal redetachment, I would like to put an encircling band to mitigate that issue. The role of prophylactic laser photocoagulation could have been a question, and I have done that, and it has actually not helped. The eye I did the laser did develop the retinal detachment. The eye which I left alone, didn't do any prophylactic laser, never developed any. So laser photocoagulation itself may create retinal folds if you're treating the necrotic retina, if you happen to treat over the necrotic retina. So we may have to, during surgery, excise part of that necrotic retina because it's very difficult, as I said, and put in a silicone oil. And we had excellent outcome in some of these patients. So this is, I think, the comment I'd like to make.
Thank you. Dr. Fernando, we would also like your comments on the surgical aspect. When would you intervene and any special surgical precautions, and how would you handle the posterior vitreous and the peripheral membranes?
Thank you. Well, in terms of the surgery, I thought it was done very beautifully in this case. And when there is already a retinal detachment, I think the mainstay of therapy is vitrectomy and detachment of the posterior hyaloid and endolaser and the use of silicone oil. I use a sclerobuccal only if there is a peripheral PVR, but it's not present in all the cases. I think that because in my patients, I try to use steroids as well as antiviral therapy. That decreases inflammation, and the control of inflammation is important to decrease the chances of contraction and development of PVR. Then if the patient has not developed PVR, I don't think that you need to place a buccal. But my issue is that I think that these cases do develop a retinal detachment very frequently. The studies have shown anywhere from 50 to 80%. And the reality in clinical practice is that many of these cases do develop a retinal detachment. And so if I have a patient that is a fellow eye, already lost one eye for other reasons or another acute retinal necrosis, episode, or a patient that is not responding well to treatment, if the lesions are extensive and active, because I agree with Russell, the extension of retinitis and activity are risk factors for the development of retinal detachment, I like to perform prophylactic vitrectomy. And some of the most beautiful cases that I have are those that where I can perform prophylactic vitrectomy, and you can save an eye. It's much better to get in prophylactically than getting in when there is already a retinal detachment. And surprisingly, detaching the vitreous is much easier early on when there is no necrosis in healing of the lesions in the periphery. What I like to do is to open a small hole. This is a little trick that I use, a small hole in the periphery of the posterior hyaloid, and then inject perfluorocarbon. And we have called this technique perfluorodissection, and that separates atraumatically the posterior hyaloid to detach the posterior hyaloid completely. And we can use this in cases of endophthalmitis in different etiologies. And that allows us to preserve the retina with the least amount of iatrogenic tears possible. And then again, complete the vitrectomy, perfluorocarbon, laser, and silicone oil. Again, plus minus buccal, depending on the PVR in the periphery.
I think, Dr. Fernando, what you mentioned about posterior hyaloid is very important. And from whatever few cases I have done, what I have realized is that we need to tackle the posterior hyaloid. And probably earlier we were taught that an inflamed eye, we should not touch too much or apply too much suction or not attempt a complete PVD. But I have realized that if you tend to leave posterior hyaloid in the postoperative period, they tend to develop early PVR and recurrent detachments. So as Dr. Amod mentioned, that it is quite difficult to handle it, but yet it must be handled. And many times we are able to induce a peripheral vitreous detachment from the mid periphery rather than from a disc. So wherever you can get the membrane, just pull it off, or from a membrane, you can get the hyaloid, or even sometimes doing an ILM leads you to the edge of the hyaloid. And the posterior hyaloid removal might be somewhere in between the surgery, not as the initial part like you do in a macular hole surgery. But yes, we must remove the posterior hyaloid as much as possible to get a better postoperative result. On the other hand, yes, there always have to be a balance. You don't want to be an over-aggressive surgeon and cause too many breaks as well. Yeah.
Totally agree.
In these cases, we must follow up regularly so that the change in the other eye can be detected early. And two things important, at what time the laser should be done and the VR should be done, vitrectomy should be done. As the majority of the cases, they get detachment over a time. So they should be under close supervision so that as soon as the detachment starts, we should be able to do the surgery. Thank you.
Dr. Rupesh, would you like to add something about your experience with acute retinal necrosis?
I think quite well covered. And I was just thinking, and maybe a question for our discussion as well. Couple of points. I think I do try to give Foscarnet, but we have, what I do is Foscarnet available in 500 milligram. It's quite a big vial. And when you give it, you just take it out and just take in 0.1 ml of it. So you are still left with quite a lot of Foscarnet, and that is usually thrown off and the patient cannot use it, and it's quite expensive. What I try to do is also I try to speak to our ID colleagues and give them the intravenous slow dose of Foscarnet rather than wasting it. It goes on systemically as well. And at the same time, immediately try to put them on whether it is, you're talking about IV acyclovir if you're able to admit the patient, but certain time if you're not able to admit, oral well acyclovir for the reasons very clearly mentioned and very nicely shown by Sheikh in her slide is the bioavailability of 5 to 10 milligram per kg body weight. It gives you a good body weight. The other thing, I was not quite convinced with the dose of steroid you have given of 40 milligram. I would probably go a little bit more higher dose. I don't know the body weight of it, but I will like to go to, I think you've given 40 milligram of prednisolone, if I'm not wrong, to start with. I will probably go little higher dose if it is possible, up to 60 or even up to 80 milligram. If it is possible, start early, start strong enough. So sometimes it is ignored that immunosuppression, or particularly in this cases, the inflammation has to be dampened very quickly. I've tried in few patients IV methylprednisolone as well. Now, I know I don't want you to enter into this controversy of IV methylprednisolone, but after giving successful for 2 days or 3 days of antiviral, and you know that inflammation is quite hitting high, you want to get. I know Professor Gupta is smiling also, but don't want you to really enter into that controversy. But some cases you can take a call about which patient is vision threatening and if you want to give, but definitely high dose steroid is something I prefer. But more or less the similar approach. And just one more little bit of pharmacology kind of point of view. If you want to inject and you don't want to inject foscarnet, ganciclovir, by its property of DNA elongation, can also be used against herpes virus, though it is not as effective. It is more effective against CMV virus, but it is 20% effective against herpes 1 and herpes, I think herpes 2 or herpes 1, one of that, and can be used in some of the cases where you don't have access to foscarnet for any reasons, and you can just use it. That's another point. Yeah, thank you.
That's an important suggestion for us because we don't have foscarnet. Maybe we can try intravitreal in some cases. Dr. Vinod, your comments on surgery or any other aspects of ARN?
I think surgery is challenging in these cases because of the simple fact that if they present early, the retina is friable. If they present late, there are lots of membrane formation which are very difficult to dissect especially from the peripheral part of the retina. And as Dr. Fernando said, silicone oil is the way to go in these cases. And many of these cases probably require lifelong tamponade with viscous silicone oil. So that is something all I want to say. And before we hand it back to Dr. Manisha, there is a last question. I think Dr. Manisha can answer it, in fact. How to manage a case which has clinical picture and laboratory results positive for both ocular toxoplasmosis and ocular tuberculosis?
I think I would request Professor Amod Gupta sir to answer that question.
I think we would have loved Professor Vaishali to summarize, who was supposed to summarize in the end, but then Professor Amod Gupta is here, so who's better than that? So sir, we would like to summarize the entire symposium. Thank you, sir.
Very interesting, and you yourself, Rohan, started the ball rolling on the subject of the webinar today of infectious retinitis, and very challenging and interesting cases were shown of CMV retinitis, acute retinal necrosis, toxoplasma presented as acute retinal necrosis, as well as the challenging situation of systemic vasculitis presenting in the eye, which of course discussion on blue sclera, by Rupesh was fantastic, that there could be a non-inflammatory kind of subclinical inflammation because of ischemia. I was not aware of that, but I'm aware that there are several diseases, collagen disorders like Marfan's, like Ehlers-Danlos syndrome, which tend to have a thin sclera. In this particular patient, if I recall correctly, she did have those tortuous dilated episcleral vessels. So my own best guess would be we are seeing a spectrum where relapsing polychondritis and probably Takayasu arthritis, because these vasculitis group, rheumatologists, they keep revising the criteria and they come up with mixed pictures. So, that's one. Now, as far as infectious retinitis, the message should go again and again that please don't start corticosteroids. Specifically, if you don't have a lab available to you for testing, maybe it's good to pass on these patients to a center where you may have lab facilities, or you may have, now India does have probably uveitis experts spread all across the nation, more than, if I'm not mistaken, more than 500 experts or experts in the making who can make a reasonable diagnosis of infectious retinitis. So I think the message going out is that beware of starting corticosteroids. And another message I would like to pass on is that please dilate your pupil and do an indirect ophthalmoscopy to look for peripheral lesions, like in the first case again, and some of these cases of when you think there is a optic neuritis or ischemic optic neuropathy, you might have a viral infection sitting in the periphery. and it might be beginning and presenting as optic neuropathy, and you start on high dose corticosteroids. So we have burnt our fingers, not looking at the periphery of the retina. So complete ocular examination. So you can't hide behind that, look, I am only a comprehensive ophthalmologist. I don't have the insight into uveitis. So I guess it's high time the comprehensive ophthalmologist also need to be able to do a complete ocular examination and flag those issues which are threatening vision right away, and whether they can deal with it. These are hot potatoes. Are you going to burn your hand dealing with this patient, keeping them with you longer than is required, or pass it on? So pass it on. There are experts all across the country. Within a matter of a few hours, they can reach the expert. And rather than keep fiddling with I've seen them starting with oral steroids, not working, going with posterior subcanal log, not working, putting in nasodex implant, not working, waiting for maybe 8 months, 9 months before six patient goes blind. They keep waiting. Now you need to watch your patient, as I think was pointed out by Rupesh in the course of discussion, that please take a fundus picture. Whether you have a conventional fundus camera, or now many places do have the wide angle or ultra wide angle pictures, so that you can monitor the progress, because it is very important for you to realize whether my patient is responding to the treatment that I have given or not responding. So you need to change your mind. So you need to watch this patient. You can't tell the patient to go home for a couple of weeks while you are trying to treat a patient of infectious retinitis. So you like to watch them, maybe every other day. You want to see what's happening and document, because our memory is rather weak. It cannot remember as well as a fundus camera can. So when you look back at the patient picture, the previous picture, you know whether patient is responding or not responding, rather than have only a vague clinical idea that my patient is doing better. So these are some of the takeaway messages from this webinar, which I could think of. Thank you very much. I think I thoroughly enjoyed the presentations and the discussions by very, very eminent experts, Professor Russell Reed, Professor Arivello, and Professor Rupesh Agarwal. It's very rare to have this spectrum of experts opining on patients, which can be really challenging, and they might have more experience in dealing with these kind of cases in their practices. So we are enriched by their participation, and I do hope that we'll continue to have their participation in our programs in future as well, because we as a country, in India, and I'm sure people are participating from across the world, get enriched by these experiences of the cases that are discussed threadbare. Thank you very much for participation.
Thank you so much, Amol sir, for beautifully summarizing the entire session. And now I would just like to thank all the panelists, including Professor Amol Gupta sir, Dr. Russell, Dr. Fernando, and Dr. Rupesh Agarwal for joining today as expert panelists. I think we've had some great discussions and some great case presentations. The winner for today's case presentation is going to be declared in the next, that is the 6th Uveitis Grand Round, which is going to be held on 31st of July. And it is going to be presented by LV Prasad Eye Institute, Hyderabad. Our annual conference of the Uveitis Society of India is going to be held from 14th to 16th of October, again at Hyderabad. It is being hosted by LV Prasad Eye Institute. So I would request all of you to kindly register, as the early bird registration is still on. And we also have the abstract submission going on right now, which is going to end on 2nd of July. So please make best use of that. And thank you once again. I think we've had some very interesting session today, covering the entire spectrum of retinitis, and hope to see you all in person during the annual conference. Thank you, and have a great evening.
Thank you,
Thank
Manisha.
you. I would again thank Uveitis Society and all the panelists. Thank you very much. Thank you for giving our institution an opportunity.
Thank you. Thank you.
Yes, thank you.